gosh, are we so excited? We have Caitlin, I'm glad you could make it. Haley, yay. Lynn, I haven't seen you. Where have you been? Melanie is back. Nuria is back. So is Orit, our rock star Orit. We were just on a call that I was teaching for our 30-day EKG challenge crowd. And Orit got a really star answer right. So let's just applaud her. Haley, happy Wednesday. I know it's Wednesday. It feels later in the week to me, but hopefully you guys are doing well. And let's go ahead and hit record. Crystal is here. Oh, I got to tell you a story about Crystal. So we're going to give away some badges tonight. And we were giving them away for participation. And Crystal said, hey, if so this is how our current group of you guys is, okay? Talk about setting the tone. Crystal said, if I'm one of the people, then you can give mine to somebody else because I already have one. And so she took herself out of the running so that you guys could win. How about that? Right? So anyway, I just thought I wanted to share that because she's so humble. It means a lot that she did that for you guys. So, and you were definitely in the running. So talking about in the running, I have the people that for the badges. My dog is here. Remy's here. What, baby? I'm about to do the giveaway. I'm about to do the badge giveaway. This has nothing to do with you. What? Okay, so we have the names in the bowl, and we're going to pick two winners for the badges. Remember, let me show you what the badge is. This is the prize. Yeah, remember that? So let's give these away. So the first winner is Caitlin. I see you're on, Caitlin. Caitlin. Yay. So message me your address. I could pop this in the mail for you tomorrow. And then our another winner, chicken dinner, is Mary. I can't read my writing. Mary Menino. I don't see you on Zoom. Hopefully you're on Facebook, but message me because you're also a winner. So speaking of Facebook, let's get ourselves in the right group so we know where we are before we kick it off. I know, so exciting. And we also are going to choose our scholarship winner tonight, and we're going to do it out of the bowl as well. Okay. So yeah, he did want to help pick. I know, KJ. Okay, yes, congratulations. Yay. So if we see Mary Menino hop on, let's tell her that she won. Okay, so let's actually get our PowerPoint ready to go. Get us in the right place, and then we'll share our screen and announce all the exciting. Okay, so welcome back to the 3-day EKG challenge. We are on night 3, and we are doing the 12 leads tonight. Okay, so that is our plan, and yeah. So we're going to talk about 12 leads, all things 12 leads. KJ, you probably recognize this. You actually got me this shirt. So I wore it to this photo shoot to honor this great shirt. So the story behind this shirt, and I'm stalling for time also, but the story, KJ got me this shirt, and they actually are a really great company that I believe the proceeds, correct me if I'm wrong, the proceeds go towards people with congenital heart disease. Is that right, KJ? Or some portion of the proceeds. And it's all about, this company is all about unplugging and getting away from technology, the opposite of what we're doing tonight, for pediatric patients with heart disease. So it's got like, I think a mountain and, some trees and a moon and stars. It's just a really beautiful piece of work. So anyway, that's the skinny on that. But let's kick it off and do our night 3. All right, so let's get the most important thing out of the way, what you guys all want to know. I actually have to put the new names in the bowl. I'm going to really quickly, I have the people's names right here. I'm going to bold them. I'm going to bowl while I'm talking to you. So the people that got nominated to be in this, well, you weren't nominated, you earned it. I usually, honestly, if you've been in my 3-day EKG challenge before, I just pick somebody. But this time it was too hard. You were all being so kind to each other and lifting each other up and doing all the things I asked you to do in honor of being like my dad, a wonderful person, and bringing that good energy to our community, that there are a bunch of you in this bowl. So one of you is going to get a scholarship, a 1-month scholarship into our 30-day EKG challenge that starts next week. Matt, you're here. Yay. And in that challenge, okay, whoever wins this, you're going to get to go to all the live classes, but also get to watch everything we've done in a month, right? In the last 3 years. So you could I'll show you at the end what the topics are that you can pick from that you want to watch. I've recorded stuff, but it's just like this community, but like a little bit more close knit. And we're not going to be in this group after today, right? Doing the classes, we go over to the 30-day, we kind of continue it on. And so you're going to get to keep that continuity, keep the friendship, whoever one of you who's gotten chosen, and I'll announce it in a minute. But you get to have that. And it's a really special, unique thing. And I used to give away a scholarship just based on random, but I don't do that anymore because the 30-day EKG challenge is become a community and a place that people come for inspiration and to learn and to be supported. That's the only people that are allowed in. So you guys have demonstrated that you are that. So, okay, let's get out of that. Okay, so let me mix up the names. And this one wants to be chosen, whoever this is. Stephanie Fluid. Stephanie Fluid. I don't know. Are you on, Stephanie? Are you here with us tonight? Let me see. Participants. Stephanie Fluid. I don't see her. Oh, Stephanie, you won. Well, hopefully. Oh, Mary, did you see that you won a badge? Hopefully somebody told you, Mary, you won a badge. So you got to send me your address, you and Caitlin. And Stephanie Fluid won our 30-day EKGs challenge scholarship. So Stephanie, please get me your info so I can make sure you get access. Who else was in there? Melanie was in there. Crystal Larimore. Kakisha was in there, and so was Michelle Roach. So there was a lot of good people in there. So you all had a chance of winning. But I just want to say thank you all for being so amazing. Okay. And hopefully Stephanie sees this and she joins us in her challenge with us. So all right, now let's get on with it already, right? All the prizes are so fun, but let's come learn what we came to learn. So here's the thing. In the 30-day EKG challenge, there's a coach. His name is David White, and he's the smartest one of all of us. And he's paramedic, and he teaches, basically a lot of topics, most of our more advanced stuff, but he also teaches the basics like this. And so one of his sayings, there's sushi on here for a reason. One of his sayings is, you can trust the EKG software interpretation about as much as you can trust gas station sushi, which, as you know, is not a lot, right? And so he has this whole saying where he takes the EKG and he tells his partner, rip off the top. I don't even want to see it, or fold it, and then give me the EKG, because he works on the ambulance. And there's some power in that because he's not being persuaded the wrong direction. And I was just talking about this in the class I was teaching in our 30-day EKG challenge about how, they do have AI now that's come out in some countries for interpreting EKGs, because there's AI for everything now, right? But I've tested it out. And the cool thing is I've tested it against, I've had the EKG, I run it through the software, and then I'm watching the patient's angiogram all at once. And not only is it missing there, but it's missing the actual interpretation. It's missing the rhythm. It's not very accurate. So a long way from that. So that means that in the meantime, we can actually know this stuff because the machine doesn't know it. So that leaves us, unfortunately, fighting it out. So anyway, moving along. It's important to know what normal is. And so there's a couple key things. This is my dog, Remy. He tried to come on camera a little while ago, but he was too shy. When he's not trying to help me pick winners, he's out hunting STEMI with Remy. But he says, know what normal is. So the T waves must all be upright in all but AVR and V1. If they're not, there's a problem. The intervals must be normal. Yes, Mr. T wave is David. Exactly. I know. He actually, Damaris, you'll appreciate this. He moved his study hall to Friday nights because he calls it Friday Night Showdown now. And he did that because everybody in the group said they wanted it on Friday, so he moved it. So now we have a Friday night date with David. It's so fun. But anyway, looking at the voltage, is it small or tall? And is the family intact? Meaning, is the P the mom, the QRS the dad, and the T the baby, are they all moving along the EKG together? If so, then we are happy. So let's talk about the EKG and the anatomy of an EKG. So let's look at this together. I'm going to move this over here. So first things first, EKG terms, right? We talked about how important they are, but let's put them into effect. So right off the bat, we have an interpretation of the EKG. So it says there is a sinus bradycardia. So if you were here at last night's, you know that a heart rate of 42 when someone has a P wave that is consistent, right, with a skinny QRS, that is indeed sinus brady. So the machine is right there. Yay, machine. And it says borderline ECG. It doesn't really tell us why. Not real helpful, but I think I know why it's saying that. And it's saying that because it's slow, but also there is, a little bit of actual, if you look down here, there's a little bit of variation in this long lead strip. So this is the rhythm strip or long lead strip. But they're still, the P waves are still the same shape, the same morphology. So this could be a sinus arrhythmia. This could be sinus with PACs. But the thing is no matter which way you went with that, if you missed it and you were like, oh, it's a sinus arrhythmia, but it was really sinus with PACs, nobody's going to die. That's the great news, right? But just looking at this, noticing that, yeah, that R to R is a little bit varied. So I'm noticing that and I'm putting it on my radar. Now, the other term that I really want you to get comfortable with is the isoelectric line, which is right here. And so when we talk about 12 leads, when we do any class, you'll always see KJ here who will say, yeah, the mom, dad, baby. I know, I hope so, Mary. Yeah, Crystal, you should join us. You are really smart. Totally. I know. We have a lot of smart people that have been coming and impressing me, really. But going back, the isoelectric is draw your lines, okay? And we're lining up with another terminology, the end of the T to the beginning of the P. That's the TP segment. That is the most isoelectric line, and the one that you're going to use when you start looking for your ST segment elevation, because that's going to be the thing that really helps you sort it out, okay? And then also, I just want to throw a little love on this EKG because if you look at AVR and V1, they're inverted where they should be. And this guy's upright, this guy's upright, 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 and upright. So everyone, all the T waves are following the rules, except for you could make an argument that potentially the baby is a little bit bigger than it should be, but that's probably happening because the dad isn't very tall. So you always have to put it in relative proportion, okay? How tall is the dad and what's the baby doing? So whenever you have a bradycardic rhythm too, the other thing that you have to consider is ACS with bradycardia. And so let me talk about this real quick. No, come here and help me solve STEMIs. So when we talk about Brady, one of the first things you should think about is hyper K. And if you work in an ER, you can rule it out really quickly. You should also think about ACS. You should think about them being over medicated, maybe too many beta blockers or too much beta blocker. They could be hypothermic. That's another thing. Totally. But that's, essentially Brady. And, also what's going on with your sinus node? Is it sick? Also known as sick sinus? Okay. And so with this guy, actually, I believe he ended up being over medicated with beta blockers. And it was a situation of he was already on a beta blocker, but he was discharged on one. And they just he didn't know. The hospitalist didn't know, right? So that's why when they follow up with you in the office, and that's how I met this patient, you always ask to look at their medications. You ask them to put their bottles on the table and you look at them, and you will find duplicates more often than not. Okay, and then let's talk about conduction 2 and briefly just run through the conduction again, because we did this, I believe, last night. The sinus node, okay, AV down to the bundles. We know that the bundles are working because the QRS is skinny, and we know that the sinus node is still working because there is a P. And, it is a little hard to see a P in lead 3. You can definitely see it in this complex, which is probably part of AVF. But another little secret trick is if you, like, for example, if you understand that you're looking at this EKG and it's 12 leads of the heart looking at the same thing at the same time, well, different things at the same time, but the same heart from different views, then you know that if you see a T wave or a P wave over here and here, there has to be, there is a P wave. You're just not seeing it. So one thing I do is I find a place where I'm seeing it and I draw a line all the way up and I go all the way down. And I'm like, oh, that's where it is. It's right there. I just didn't see it. So those are just little tricks. And the other thing is if you didn't have a P, this would not be a number. It would be an asterisk because it wouldn't be able to measure the PR interval. So just some little basics, fun little tidbits, more than anything. Okay, let's see what's up in the chat. The little blue pill. Yes. Oh my gosh. I know. There's only one that I know when they talk about it, and it looks like a football, and that's usually carvedilol. See, that's the only one. But anyway, let's also talk about normal EKG a little bit more, because knowing normal helps us sort out the abnormal, which are going to see some abnormals. Okay, so first things first, we must know that it's a normal EKG for a couple reasons. Now, first of all the T waves are following the rules. Yay. When we do our lines all the way across, there's no ST elevation or depression. We know that we have a P for VQRS. The T is nice and close to its own dad, not too far. And the axis is normal, okay? And all these numbers actually are. So let's talk about them really quick, okay? So what are the normal intervals? It's important to know that. So the rate should be between 60 and 100. That's working about pretty good. The PR should be 120 to 200 milliseconds. The QRS should be 120 or less, aka 3 small boxes. Then the QTC should be 460 or less, 460 or less. And then the last thing is the axis, and that should be between 0 to 90. And it is, okay? So you can actually use this now as a cheat sheet, and you can see that all the intervals are normal, okay? Okay, yeah. I'm sorry. The hospital has all my records. I know, I hate that too. Okay, so this is a normal EKG, looking good. This is what we want to see. And the closer it is to normal, the closer the machine will have on getting it right. All right, now let's keep going. So this is an example of the gas station sushi that David is talking about. So let's just quickly show you. This says, hey, normal sinus, normal EKG. La 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 la. That's what I imagine the machine sounds like. No, machine, it's not, because we just said the PR interval should be 120 to 200. Okay, and it's not. It's actually shorter than that. So when you see a PR that's less than that, you need to go looking for WPW. How are you going to do that? You're going to, let's write it out for you guys. And let's go over here. Let's move it. Okay, yeah. So you're going to look for the W of Wolff Parkinson's White. which is wave delta. You're gonna be looking for the P, which is PR interval short. And you're gonna be looking for the next W, which is wide wave. And that would be a QRS that's widened. So QRS that's wide. And so let's do that. Let's look for it. So go over here, go to the beginning of the QRS, see if there's any slurring. There isn't. And what it would look like, just to show you, is this is going to be a great drawing. Eye roll, eye roll. So P and then kind of a slur. Actually, that's pretty good. And then the D. Okay, so look how nice and tight and skinny that is. This right here is the delta. We don't have that. So yes, we do have PR interval that's 116, that's short, but there's no delta. That's just a short PR interval. But the thing that's also not normal is that this T wave is inverted. And it shouldn't be. And you can honestly argue that this one is too. So technically, there's two that have inverted T's. So that's not normal. So as you can see, we can't trust the machine. Can't trust. Look for the QRS with a kickstand. I like that. Yeah, it doesn't look normal. Good job, Melanie. Melanie's our rock star. Okay. So anyway, just know that the machine is gas station sushi, and that's just proof. Okay. All right, what else do we want to talk about? We were okay. So I think what we want to bring up now is what the leads are. So really quickly, we got to talk about what part of the heart the leads are looking at. So let me think. I want to show you something really cool. Really, I'm going to go outside the script for a minute. Show you guys something super cool. This is going to be like groundbreaking. I'm going to go grab my heart, my big heart, and I'm going to stop this really quick. Let me grab my heart. All right. So, okay. This is going to, if you've never seen this, this is going to be like, oh my gosh, so good. Okay. So this is Mr. Big Heart. I know I'm going rogue. It's good to go off script. Okay. Here's the heart. And basically, let's talk about the anatomy real quick. So this is the front of the heart, the anterior wall. Okay. And this is the inferior, and this is the lateral. So when we're looking at the 12 lead, this is what we're looking at. Concept check. Okay. If you take this 12 lead, and let's just say that this is my EKG. Okay. So if we take the 12 lead and my heart sits like this in my chest, and we put this here, this is exactly what we're looking at. So what does that mean? It means that that's the way you can literally remember this. Because I'm going to take this away and I'm going to bring it back, but I'm going to take it away for a minute. And I'm going to use my hand. I'm going to use my hand as the heart. Okay. So my heart's sitting in my chest. When you take this and you put it over my hand, you can see I need like an assistant. Remy, where are you? V1 and V2, which are right here, are right over the septum because those are the septal leads. Okay. And Q3 and AVF are on the bottom inferior wall. Okay. 2, 3, and F. And then B5 and B6 are on the lateral wall. Okay. And when you look at it that way, if you're ever like stuck and you're, wherever you are, you could take your EKG and you could do this. And you could be like, what are those leads again? Oh, of course that's my septum. And of course V1 and V2 are right there because they're the septal leads. And then this is where V3 and V4 are. Those are the anterior leads. And then it just like, so Caitlin, it does make more sense. And honestly, nobody taught me that. I actually was like, I don't know, 8 years into teaching this. And one day in the shower, I just had this idea of how to show somebody. And I'm sharing it with you. Remy, what are you doing, buddy? Okay. So, but let me show you the rest of this. Okay. So this is where it all comes together. When we're talking about STEMI, we're talking about basically 3 arteries. Well, maybe 4. And mostly we're talking about the big one. This one right here. Okay. This is the left anterior descending, which feeds the front of the heart. If you attack this, if you clot it up with plaque and it feeds the pumping part of the heart is going to get upset and it's going to get tachycardic. And the blood pressure is going to raise because it's going to try to feed that part no matter what, because this is the pumper. We cannot have the pumper fail. So that's what it's going to do. But that's why you'll see that people come in well, I call it, they come in high and fast. Heart and fast, blood pressure is high, but there's a tipping point, because if this is blocked for too long or too much, then people will go into cardiogenic shock. And then they'll become, tachycardic and hypotensive. And that's, really, really bad. Okay, cardiogenic shock. But also, there's a little artery that's proximal right here. And if this is the LAD, this is the more proximal one. This is the left main. And the left main, if you block that, you block the LAD and you block the other artery that goes off of there, which is the circumflex. And the circumflex feeds the lateral wall. So basically, this would be like the worst place to have plaque. And that's why a lot of times if they have plaque here, they go for CABG, because it's too risky. And so lastly, the inferior wall, which is like my heart sits like this, the inferior wall is fed by the right coronary artery. And the right coronary artery also feeds the sinus node. So that's why when these patients come in, you will see them be sometimes Brady, because if the sinus node is getting choked out, so to speak, then it's not able to do its job. So if you have sick sinus, ischemia is one of the first things to think of. And you can also lose your P because the sinus node stops working, and then you'll just have like a junctional rhythm. That's also possible. And if you affect a lot of this, including the right ventricle, then a lot of times they'll get really hypotensive too. So just understanding the anatomy of this is really critical. And then you can get stents into here and the circ and the RCA, but we can't always, we can't always stent everything. Sometimes people need CABGs. You didn't start, I'm seeing a comment. You didn't start recording again? I know we haven't stopped recording. No worries. You can go back and review this, no problem. But let me tell you one other thing. So since we still have Mr. Big Heart out, when we talk about STEMI, we're going to talk about contiguous leads and reciprocal changes terminology. So contiguous leads just means what leads are fed by that artery. So for example, V1 through V4 are fed by the LAD. Okay. And when they're fed by the LAD, we're looking for 2 leads of elevation in a contiguous lead. But we must also see, to meet STEMI criteria, we must have changes, reciprocal changes, which are opposite. So basically, when we teach this in the 30-day, I actually give you a graphic that explains this, but basically, and we go over it, we practice it, but the concept is that anything that happens here, the opposite must happen here. And so if you think about that, you know that by looking at the 12 lead, you're not monitoring the back of the heart, but you still see there's vessels there, right? So this is why it's like nobody's looking at this. But how would we know it's in trouble? Because of reciprocal changes. So that's why if you have depression here, you know that there's probably elevation back here. And so that, in a nutshell, my friends, is putting together the anatomy with the EKG and tying it all together in a visual way, because that's the best way, is having somebody kind of walk you through it. And one last thing while we're here is that the unfortunate thing is that sometimes, look, we can stent the big stuff, but we can't get into these little small things. Yeah, we can't get into these small things. And if we can't, they can still have angina or angina, however you want to say it. And then they are really uncomfortable. But that's when we manage them medically and do things like Renexa and other things. Okay, so let me catch up on the comments really quick and then I'll start sharing my screen. Let's see. Yes, yes, yes. Okay. Why isn't this more common practice? I know. I know. I agree. That's why we do this. Literally, that's why. Okay. So we were just going over this, but we did it in a little bit better way, I think, on the heart. These are the septal leads. These are the inferiors. And then these are the laterals, right? These are the anteriors. And these are also the laterals. Okay. So just running through this. And in the 30-day, we actually, as Matt was saying, we color code this. That EKG, I actually send you this EKG and we color code it. We have you write the intervals on it. We send you the crayons even to make it easier. So anyway, it's helpful when you see it, but then you also do it because it cements it. There's something about, they say, writing that makes you understand things and retain it like 25% more. And I believe that that's true. I believe that if you are a tactile learner, and I know I am one, that you need to touch things, feel things, like process them through your hands. Or if you're a combination of learners, like that piece is critically important for you to learn it. But if you're a visual learner, then that thing I just did probably really helped you. So it's just like when you learn this, you have to touch all the different points of learning this because it's so complex. And that's probably why when you were reading a book, it didn't always make sense because you weren't able to do all the parts of the learning, right? So anyway, don't think it was you as the moral of the story. If you're struggling with this, it's not you. It is just the way you haven't been presented it in a way where it's made sense yet. So Michelle, this is Coach Michelle. She's currently traveling the country. She usually teaches this with me, and I miss her so much. Yes, there's actually a breakdown on how the brain learns. Really? Oh, I didn't know that, Melanie. Why do you think I write notes for you? Now it makes sense. Oh my gosh. Okay. Blue is better. Oh, you guys, my dog, I'm sorry. He's going crazy today. So 10-step system. So Michelle usually teaches this with me. And this is our little system when people are new that we use to teach them how to do this. Now, like in our class, I just got off of teaching. I just taught this on one EKG all the way through. So basically, it's important when you're first learning to have some sort of system. But I want to talk a little bit about it and why I chose to put things in there that will help you not get stuck in the weeds of the small things and really keep your eyes focused. I have to shut my door because my dog won't stop barking for some reason. Hey, you're interrupting the 3A. Okay. All right, back to where we were. So big sick versus little sick. If you have an EKG that's a STEMI, that's asystole, that's VTAC, that's VFib, you're not going to do any of this list. You're going to not pass go, not collect 200. You're going to actually fix the patient. And that's it, right? Otherwise, cool. If they're little sick, like, maybe some little funky things like some T-wave issues, then you can go down and look at the rate, look at the rhythm, look at the intervals, look at the axis, and then look at the ST segments, drawing your lines as KJ always teaches us, and then looking at the size. Because the other thing too, going back to Mr. Bigheart, he has all the answers, is that we're measuring the amount of electricity that's coming from here that's being transmitted up to the chest wall. And it's telling us how big the heart muscle is. So like if there's a lot of heart muscle, you're going to have big R waves, and vice versa. If there's a small heart muscle or it's not contracting well, or you have something like amyloidosis, you're going to have small voltage. And then so you need to look at that. And then you have to look at all the T waves. And I literally on this class I just did, I'm going to share it with you guys because it was so fun. So I made a list, and we're going to go super geeky, but I was like, okay, what are we looking at the T waves for? We're looking at the T waves for a lot of things. Okay. So we're looking to see, are they too big? And if they are, we're thinking about hyperkalemia, kalemia, and ischemia. We're looking at, are they biphasic? That's ischemia till proven otherwise. We're looking at, are they inverted? And if so, are they symmetric? If they are, we're thinking about lots of things, ischemia being at the top of the list. Are they super flat? That could be hypokalemia. Remember T-wave jail, if you were here for that, kalemia. And what else we're looking for? Are they too far away from their dad? That could be prolonged QT. And then are they a teenage T-wave? Are they almost as big or too big for their britches? That's ischemia. And I was just talking about, I'm going to really quickly go down. I was talking about the teenage T-waves because this is, I think I mentioned this, but I'm going to mention it again because I really, if we were in a class and like we were live with each other and there was a moment where, the teacher steps on the ground, like, remember this, right? This thing is so important. It's so huge that it can't be glossed over. And that's that article that came out where it listed new STEMI equivalents, and posterior STEMI is one of them. So are hyperacute T waves, which is what we're talking about, which is the teenage T waves. They're too big for the QRS that they belong to. So with all that being said, that article is very important because it also talks about other T wave things like D Winters. If you don't know what that is, that's actually now a STEMI equivalent. There's some other stuff too, but those are two T-wave things that are on the list of new STEMI equivalents. So this article was published. You can pull it up right now, November 15th, 2022. It was called in JACC, and it was called like consensus pathway chest pain in the ER. If you just put this into Google, it'll take you right there. There's a table in there that lists all the new STEMI equivalents. So like literally guys, like this is a serious moment because our lives as providers changed forever that day when they released these new guidelines, because they don't just apply to people in the ER. They apply to all of us, these new STEMI criteria. But like, where was everybody? What were they making TikToks about this, or were they like making reels? No, they just put out this article in a magazine right near Thanksgiving when people are like shopping for the turkey and planning their PTO, right? And this is dangerous that it's not made like totally public to you and just like spoon fed. Honestly, I feel like it should be spoon fed to each and every one of us. I really do, because it's a game changer. So anyway, if you want to brush up on that article and that table, when you look at it, you'll know all the STEMI equivalents are on the top, and then all the urgent revascularization stuff is on the bottom. And so they're, the inverted T waves are on the bottom of that list. That's why I talk about them. And it used to be that I would tell people, hyperacute T waves. When I taught this, 10 years ago, I was like, oh, hyperacute T waves, those are STEMI precursors. But now they've actually upgraded them because they realize, well, they're going to turn into a STEMI within minutes. So let's just make them a STEMI equivalent. And that's why I was talking about earlier in the last couple of days, I was telling you that there's a paradigm shift happening to where it's not enough to just know STEMI. Because I talked to a lot of people and I'm like, oh, I feel okay with EKGs. I mean, I know the big stuff, but you know what? No, you don't. Because the big stuff is the little stuff. It's the stuff that's not going to print out on the software, that's lethal if we don't pick it up. And that's why, like, I actually made a whole class about this in our 30-day. It was like, we're going to go over this. In fact, I do it a couple different times because I think it's so important for everybody to get it. And I show you examples. We go over it and over it, because really what it takes is to see the pattern and then like be able to identify it. So it is everything. This is the key. Okay. I'm going to spill the tea. Okay. Everything is pattern recognition. Everything in learning EKGs. It really is. And so learning what these things look like, it's like the same thing with bundle branch blocks, learning what a bundle branch looks like. We actually give you a special way a little cheat sheet on them on how to do it. But yeah, in a nutshell, this is serious stuff. Okay, so Melanie, so is this why when I did the STEMI protocol for a VTAC, I was given in the instructor? VTAC is actually not on the list. So I don't know actually on that one, but maybe they were saying something else. Oh, you got the article, Crystal. Thank you for that, Crystal. You're so helpful. Oh, KJ listening out the leads. Thank you. It's like we have to make sure. Yes, Matt, exactly. Yes, thank you, thank you, thank you. The STEMI and precordial leads. Okay, so the only place that we don't have reciprocal changes is V2 and V3. Okay. Peppermint gum. Crystal, you're just a wealth of information. Okay. I think that's it. I think I caught up on all your comments. Okay. Well, I'm sure that it was amazing, but yeah, I can't comment on it without seeing it. But anyway, here's all the things. Thank you for putting the article in there, Crystal. And that's the 10 steps. So I think I was stuck on the T. And then let's do the Q's real quick. And I hope I'm not throwing too much at you, but it's just very important to know all these things, these little tiny tidbits. So Q's, okay? You guys know that Q's mean, and we talked about those night one, they mean old infarct. But maybe not, right? Maybe not. Could mean new, as in within the hour, because they can form within an hour. And then a Q can be found in something called an S1, Q3, T3, which is indicative of a PE. And then they can also be found when there's something called hypertrophic obstructive cardiomyopathy, which is lethal and dangerous. So the Q story, you're looking at for all those things about the Q. And then you cannot have a Q in V2 and V3 ever, but you can have a small q in lead 3, and it can be fine. It has to be small, less than a third the height of the QRS. Okay, so there's lots to look at in the Q. And then lastly, but not leastly, we're looking at chief complaint-based approach, right? Okay, chief complaint-based approach. What is going on with the patient? So like, for example, if you have someone with syncope, you got to look for lots of different things on the EKG. Palpitations, chest pain, they're all specific things we need to look for. And so you go back in with those eyes and look at the EKG. You've done all your stuff, but then you're going back in and looking for the specific things like S1Q3T3 if they have shortness of breath, right? If they've had syncope, HOCM would be on that list. Although today we had a patient with syncope and cardiac arrest who had a massive PE. So really we gotta always look for those things, and including family history. I love that, KJ. We're always doing that. So important. But that's basically the 10 step. And then so when you're looking at this EKG, you could use this as practice, but we're not going to do that because we're running out of time already. But tell me what you think when you see this EKG. PA. I think you mean, I don't know. Tell me what you mean, Melanie. Bring it home for us, because there's something pretty wrong with the EKG. Okay, yeah. Mary says sinus Brady with a first degree block. Okay, Crystal, if you're not seeing a P, I love that you said that. Let's because probably someone else isn't seeing it. So let's do it. Let's do the trick. Okay, so let's go over here. So let's say that right here, I see a P. And I see it pretty clearly. And I go up. There's a P. I keep going up. The P is right here. So that's another concept check. And Crystal, I'm so glad that you said that. It doesn't matter if you don't see the P in every lead. This is the beautiful thing about understanding that you're looking at the heart in 12 different views, basically, but you're looking at the same heart. So if you see the P in a couple of leads, but not in all of them, it's okay. It's still there. It's still a sinus rhythm. And that's the beauty, right? Because like right here in V1, you can see, ooh, that's a pretty one right there. But then you don't really see one in V. Well, no, it's right here. It's just that there's such a prolonged PR. And yeah, I love, Crystal, that you said that so I could point it out, because I want you guys to tell me, hey, I'm not seeing what you're putting down, Jen. Like, explain it different, explain it better. But yeah, they're just tiny. But they are very far. The P is very far, and that's a very prolonged QT, 338, or sorry, PR. But that's the secret. If you ever, when you find one, keep going, keep looking at the other leads. So anyway, what else did I want to tell you about this? So the other thing is that if you saw this patient, I hope that you would think about ischemia as a differential. I hope that you would think about hypokalemia or hyper, thinking about being over medicated. And absolutely, yes, Matt is spot on. That PEs will usually be tachycardic. Exactly. And then KJ, I would agree, potentially in V2, especially the T waves could be hyperacute. And that's why the machine is saying non-specific T wave abnormality. This is a real EKG, heart rate 44. So anyway, the long and the short of it is that the big question you want to ask that patient is, are they symptomatic? What are they feeling? Okay. And oh, Mary, yeah, look at that. Mary is bringing it up. Yep, you are absolutely right. In V1, the T wave's upright. That's a problem. And it's kind of hard to see what's happening in AVR. Like, is it up or is it down? Or is it biphasic? Really hard to say. But right here, you've got a problem. Okay, so you picked that up. Strong work, Mary. Good eye. Eagle eye. So then we talked about that already. Remy already explained it. Here's the chart with the reciprocals and leads and what they feed. But personally, this was hard for me to absorb because it's a memorization thing. I prefer to do a tactile exercise with you so that you understand it for the rest of your life instead of memorizing it over and over and over, because it leaves your brain because you don't really understand it. That's the other key, is that if you understand, like we talked about on that heart model, if you understand, it's like, it's just a whole other world. You're not struggling anymore. You can actually figure your way out of an EKG because you understand. So this is Coach Michelle with my cute heart glasses. I don't even know where they are anymore. And Coach Espery, we were out on the road having fun, teaching a conference. But let's do some practice. Okay, so we have a 71-year-old male, and his pain, I'll just tell you, sounds very cardiac. It happened, it was exertional. It feels like my last MI. No, this is nobody's real face, by the way. It goes to the jaw, back left arm. I have stents, and I feel lightheaded. So how worried are you about this guy? How worried? Oh yeah, Crystal's very worried. Mary says and you guys are spot on. Okay, so Remy, the little baby Remy says, what are your differentials? Well, I know you guys are all thinking about ACS. I am too. I'm also sort of thinking about AAA, of course, because you always got to think about that. But here's his EKG, and you can see that you guys that were worried, you were right to worry, because we have elevation and two continuous leads, and we have depression and two reciprocal leads. So is this a STEMI? Absolutely. Are they going to the cath lab? Absolutely. We just needed one small box to have to be criteria in these leads, and we needed the reciprocal changes. We have them. We're done. He's going to the cath lab. That's as easy as that. We didn't do any of the other steps because we don't need to. He's going to the cath lab. Here's another case. This is a 26-year-old male. Oh, look at you, Matt. Look at you pimping. I love it. Yeah, ask him the questions. I love it. Let's see if anybody got it. Luckily, we have two heart hospitals. Yes, you're lucky. Oh, okay. So yes, your differential is hokum for this patient, Crystal? Totally. Yes, it is on the radar for sure. But, but there's another something that should be on your radar, because he's 26 and his uncle died at 27. So that's not good. Here's his EKG. He had near syncope. Does anybody know what this is? This is a high risk finding. Any guesses? If Michelle was here, she would say we could ski in the V's. Matt says, uh-oh. This is Brugada, none other than Brugada. And there is ski slope ST elevation in V1 and V2 with no reciprocal changes. Okay. This is often going to be read as STEMI. This is why we tell you how your reciprocal changes. Hello, Anissa. So we need our reciprocal changes for sure. We don't have them. And the weird ski slope element there and the family history is very concerning for Brugada's. So this is a patient that if you saw in the clinic, it would go to the ER. Absolutely 100%. If they're in the ER, we're going to admit them and we're going to make cardiology see him. If we're cardiology, we're going to do an EP study and consider putting in a defibrillator so he doesn't die. Here's another patient. None of these real faces, of course. I just have to keep repeating that. He says, I'm weak. Okay, I know how much you love that chief complaint. I'm weak. But basically, there's a lot of things that be going on with him. He could be anemic. He could have a GI bleed from his Xarelto. He could have ACS. He could be an AFib, A flutter, all the things. So let's see what the verdict is. Okay, putting our skills to the test. Putting our skills to the test. The STEMI that we had, it was inferior. Yep, absolutely. But this one is, oh, Mary. Mary wants a posterior view. Okay. All right. Like what you're putting down. So if that was true, what would we do to get a posterior view? How could we do that? What do you guys think? Oh, look at that. KJ put it in there. V7, V8, and V9. Right. Absolutely. We could do that. V4R, we're mostly looking at the inferior wall, right? But we're going to move the leads to the back, fifth intercostal space. And it's a posterior EKG. Our right-sided is more looking at like the right ventricle and to see if it's involved. So that's like where the V4 are, but this is different. This is the posterior, okay? And so that would be the right answer if you were unsure of what you were seeing. But let me encourage you to not need that in this case, because this is like totally significant depression in the reciprocal leads, V2 and V3, right? There's just no other explanation unless the patient was tachycardic, but they're not. So there's definitely lots of depression. And if you did do V7, V8, V9, you would see elevation. Okay. So this was a posterior STEMI. And I just want to point out some more sushi. No. This is a STEMI. This went straight to the cath lab and got stented. We didn't do the V7, V8, V9. It's not wrong. In fact, that article, that if you look at it, it'll say you can do it if you're unsure. It supports it. But if you think about what it would actually take to get that, it takes a lot. It takes a tech to get it who knows what they're talking about. It also takes time, and somebody has to look up the manual how to do it, and it's confusing. And meanwhile, they could just be in the cath lab. So I just encourage you to realize that that's significant depression, and it's a mirror, like KJ said. So here's the part where we have our workbook, and I'm going to let you run through these on your own as homework. I do have the answers for you. They are here if you want them. You can come back to that. This is the part in your workbook where you can go through the 10 steps and write them. I have the answers for you that you can come back to later and watch if you want. And you can also play with this one. And basically that's just looking over if you want to play with labeling the conduction, if you want to like play with that EKG and do any of that on your own, you can. And essentially there's a lot of take homes from our 3 days together. But the big one is that the sinus or the president should always run the heart. And don't trust the software. It's all gas station sushi, not all of it, but a lot of it. Use your PQRST, use your pattern recognition. The EKG family should all be holding hands, and memorize your intervals. So important because intervals have lots of clues. And then officially, this is a wrap of our 3-day EKG challenge. And I want to thank all of you guys for being here because you have made it so fun. I'm excited for our scholarship winner. And if any of you are like thinking, okay, well, hold on, does this party have to stop? What if I want to keep learning? Like Jen, you've been talking about that dumb article all day. What if I go sit down with it and I really can't figure it out on my own and I want to join your 30-day and I want to watch that? Well, let me tell you how, along with a lot of other cool things. So this is Michelle's little basic 12-week class that she does. She gives you this card to print out and she goes through it if you like visual stuff. This is Coach David doing his study hall. So this is where you can bring EKGs to David and he will dissect them on a PowerPoint for you, which was so fun. You learned so much by that. And this is our current schedule for this month. We do one every month. So this just keeps going, right? But basically tonight in our 30 day, I did this basic 12 lead. So when you jump in, you can watch this whenever you want. And then if you jump in early enough, you can go to the first study hall of the month with David, and he goes over the EKGs you all submit. And then you can ask questions too, which is so fun. And then we're going to officially jump in on the 16th with our welcome call, where I'll show you all the way around the group. I'll show you the learning portal, all the things. And then we have an arrhythmias class where Sean comes in and he does over the shoulder stuff. I mean, his classes are amazing. Mine, basic. His is like fancy and technical, and you get to like see rhythms everywhere. And I just can't even tell you how good it is. So his arrhythmia class. Then we're going to do some cases. So if you liked those cases that we did at the end, I'm going to do that, but actually like go through more stuff, like add the labs and add the workup, and you'll get to see the stress test, and you'll get to see, you know, the cath report. So it's like all the way through. And then we're going to do bundle branch and heart blocks with Sean on the 23rd. He's so good at teaching it. And then we're going to do some arrhythmia and 12 lead practice with me, and then more study hall with David. And then we're going to do Matt, who you've seen, Matt Buchanan. He's going to do 12 lead practice. And then I'm already making the schedule for next month. Next month is going to have some heart failure again, and some farm of heart failure, along with some other cool topics. So that's just what's coming. So scholarship winner, you get a month's access to this, but you can also watch all the previous classes in the group. We've basically been doing this, I don't know, 3 or 4 years. I stopped counting, but we have tons and tons of classes. These are just some of them, right? That you can jump in and learn and, you know, watch. There's stress testing stuff, there's lipid stuff. We even go into like how to write a SOAP note, like for new providers. So those are all in there. So if you want to join us, we have 2 options now. We didn't used to have this, but we just created option 1, where it's you get, I'm going to come back to option 1. We're going to go to option 2 first. This is the new thing. Okay. So basically before you could never get in the challenge for less than 150, basically. That was, unfortunately, we couldn't go any lower than that. But what we decided to do, because we know that people are in a financial crunch right now, a lot of people are, that we made it possible for you to jump in for even just 1 month if you wanted to. Come in, see the basic classes, get your feet wet, binge watch classes from the past, and you'll have access to basically 2 Facebook groups. You'll have access to the basic learning, where it's called EKG Launchpad. That's where all the classes on Wednesdays are at 4 o'clock PST. They're all recorded. Everything's recorded. And then we have the 30-day classes in the 30-day EKG challenge group. So you get access to both groups. So like, if you're like, Jen, I'm still over here at What's the P Wave, then maybe you spend your time watching the stuff in the Launchpad, where we do a lot of cardiac anatomy and basic waves and stuff even more basic than we talked about tonight. But it's the choose your own adventure, which is really cool. And if you're like, oh, I'm like a new cardiology provider, I want to look at cardiology stuff, then that we have that too. Like, we pretty much don't just have EKGs as the moral of the story. But so if you do the $47 option, it renews every month unless you cancel, but you can easily cancel. But once you've stayed in for 5 months, I'll mail you everything in the kit, and you'll be qualified to get 14 hours of CE. So that's a good option. Ruben, I'm hoping you're putting the links for these up in the chat. Ruben, if you're still here, if you could drop the links. If not, oh, perfect. Okay, thank you. So then the other option is a pay in full, and that's the upgraded package, where you basically get to stay in for 6 months, and you would get lifetime access to the portal. Whereas on the monthly, you don't, because it shuts off as soon as you cancel. But if you do the upgraded, then you automatically can apply for the CE like the next day, obviously. You have ongoing ability to get support, the same things that the $47, but you get the kit sent out right away to you. And basically the 14-hour credits. And then the good thing is, what we do in this 30-day is when we open up like a new class, We do the basic framework for that new class that comes in. But then when you're in month 2 or month 3 or month 4, or some people we have a lifetime membership that you can get once you're done with your first set of time. A lot of people are lifetime members because they're like, well, you just keep coming up with new stuff. And the thing is I have so much new stuff now in this new position I'm in that's going to blow your minds that I literally can't wait to just like share it all with you. So we keep it fresh for the people that are in for a while, but we always have our core classes. So even if you are in for a while and you're like, I need to brush up on, I'm going to go back and start with a new class, you can do that. So this is a really good option, the $299 or the $47 per month. Either way, but that $47 allows you to come in and get a taste. If you just want to do 1 month, you can come in and get a lot of information. And we've never opened this before. And I don't know how long we're going to keep it. So if you are interested, jump in, hop in the link. It'll give you an email with the link to our groups and you can start binge watching. Okay. And then let me just share with you some of the classes. This is just some. We didn't put all of them on here. Okay. But this is just a list. And there's a document in the 30-day that if you click on it, it'll take you right to the class. Like if you want to watch Cardiac Farm, you click on it, it's a PDF, it'll take you right to the Facebook class. So much good stuff. Chest pain red flags, how do you document what's hot and what's not in cardiology, patient scenarios, cardiac murmurs, you name it, we've got it. We have tons of coaches that have joined us to do guest lectures, and we've even had pacemaker lectures, we've had advanced lipids, antiarrhythmics, long haul COVID, stress test. I mean, literally, like there's so much good stuff. We've had Michelle's classes, which are also good, and she's makes things very interactive and visual. Coach Megan, she's like our cardiology NP queen. She talks about, all sorts of inpatient stuff, diuretic dilemmas, heart failure updates, cardiac apps. This is one of our best lectures in the whole 30-day. She tells you all the cardiac apps and what are best to have on, and she shows you around. So that's in there. We have Carissa, who's our sleep queen, and she literally does pulmonary hypertension, sleep apnea stuff, PFTs, you name it, she's got it. And then David, okay, there's so many study halls that we couldn't even fit them all. We just put like the most popular ones. Like he talks about, STEMI and STEMI mimics in this one, bundle branch, AV block review, posterior MI, BTAC and SVT, how to tell the difference. Like literally, you click it, it takes you there. This is a good one. People always ask about lead placement. He does a whole thing on lead placement. So much good stuff. Then we have Coach Sean, who you're going to learn to love. And he does heart blocks. He even did an ACLS prep course. He did a med math course for paramedics, which is amazing. Comes with a workbook. And then we have some lipid testing with our lipid queen, Whitney. And we have our EPPA, Kim, who did devices, anticoagulation, AFib, you name it, she's done it. I mean, I could go on and on and on. And then lots of stuff from Camille as well. And basically, when you hang out with me in my world for 6 months, you go from being unsure to being confident. And basically, we want to bring you into our world. That's our goal. This is just one of our people that went through our 30-day. This is Alice. And she's really true. Or she's really right. You got a tough EKG to read, bring it to David, and he will break it down for you. If you have questions, there's a lot of people that will answer your questions, me included. But Michelle will, so will KJ, Matt, other group members. Like we're just kind of hanging out, ready and waiting to help you out. So we want to see you inside the 30. And then the other thing, Orit is in a rock star in our 30-day. I'm super glad that you're in. But see, that's the thing. Okay, so Orit is in our 30-day. She's in our paid program, but she's coming to our free program because she knows that there's still value, right? Because you can never get too much of this. That's the great thing. And so I think I was going to show you one more thing. Okay, I was going to show you inside the portal, and then we'll wrap it up for the night. But this is our 30-day portal. So I want to show you, if you end up joining, you're going to get instant access to this, okay? And basically, all the things at the top are the CE courses, okay? They're all on the top. And if you join at the you get lifetime access to this portal. Okay. Even if when you're no longer with us, if that's ever a thing, you still have access to all these cool cases and good lectures. But we also said, we know that, like, let's just say you're jumping in on that $47 offer and you're like, I just want to do EKGs. I don't care about AFib. I don't care about heart failure. Then we actually did the fundamentals here for you. So you could just jump here and it's organized. You don't have to search anywhere for this. You can just go here. I want to watch EKG terms. I want to watch basic rhythms, basic 12 beat, and Jen's workshop that goes with the kit that I send you. Okay. Then you just want to do that. That's fine. That's right here. But if you're like, I kind of want to learn about murmurs, or I want to learn about cardiac farm, you can go here and watch those lectures. You can get some case practice. This is where all the case practice is. And you can practice like we did tonight. If you're a cardiology provider and you really want to know about stress testing and cardiac enzymes and pre-op risk and lipids and heart valves and reading how to read the echo reports, like, you come here. But then all provider fundamentals, we also have a section, right? So if you're like, I want to learn SOAP notes, you come here. I want to learn how to document so that I don't get sued, you come here. I want to learn how to document based on a scenario you've given me, you come here. If you're encountering difficult situations, we've got an answer for you, different patient cases that are challenging, okay? We've also got a couple of things in here, right? Long haul COVID, sleep apnea primer. But the best part is that we have a daily EKG that you could, if you want to, go through. But I recommend you do this later, like after you've gone through all our stuff and maybe you're not in our group one day, or maybe you've gone through all our stuff and you feel comfortable, but you're still in our group. Whatever, you can do that. But save this part till later, because what this is this is practice. So like David and I took turns alternating, and he did like this EKG, for example. Okay. So it looks just like this, regular EKG. And he goes through step by step. And he like color codes, he marks up, he walks you through, he points, he labels, and it turns out like this. And you're like mind blown. But then you go to one of my EKGs. Here's mine. Okay, so like here I am. And I'm literally just so low tech. But I also feel like that gives you that like vibe of being over my shoulder and you're just watching. So there's 30 of these. So anyway, this is what you get when you join us. So, and he does explain everything in simple terms. So you get a supportive environment and you get this awesome kit. And I actually wanted to show you something. This is, you guys that have been around me for a while, you know that I make different themed paintings. And so I've been painting every night after I hang out with you guys. And you guys inspired this painting. Literally, you guys did. I've never made anything like this. KJ, you know that. Matt, you know that. This style, the blue, the happiness in this painting, it says friendship. That's because that's what you have all brought into this group being here with us last 3 nights. So you've actually literally inspired. They usually look something like this, but they're changing, they're morphing because of you guys. And I wanted to share that just because it's been such a special time getting to know all of you and hanging out with you. And yeah, it's been great. So if you are going to join us, we are going to have David on Friday for study hall. It's just something that's ongoing, and you don't have to go to anything, by the way. They're all recorded and stored, so you could literally go to nothing. It's also an option, and you could just watch the portal stuff. But anyway, if you're going to come, the first night that I'm going to walk you through the portal and the group and everything is going to be the 16th. And we'll do a little bit more deeper dive on terminology and some other stuff to know. And then we're just going to keep on trucking. But it's been an honor and a pleasure to be here with you guys. And yes, KJ, I am an international artist. My art will be hanging in the UK. And it'll be displayed from September 7th on for the Cardiac Arrest Awareness Project. And so yeah, save the art. If you get the kit, save this, because one day I could be worth a lot of money. I don't know. it's just good. Go on this ride with me, right? So anyway, we're gonna put this recording on the replay page. I hope you guys have been seeing that. We've been posting it every day. It should have already dropped today. It'll drop tomorrow. You can rewatch the lectures. If you want to think about joining us in the 30-day over the weekend, think about it, but definitely jump in by Tuesday. A lot of people wait till Monday night or even Tuesday to jump in, and they're like just in time for the first lecture. But it's kind of cool to be there for the first one because we get to celebrate just like this. We get to celebrate and like get to know you and hear your story if you want to share it, and you know what you want to learn. And then when you tell us that, we can actually help guide you to like, hey, you probably want to start here. Like we had a new cardiology provider join us, and I was like, oh, okay, cool, perfect. Okay, you're gonna go watch in the portal, the cardiology section. You're going to watch those first. That's your most important thing. But then try to come live. You know, you can ask EKG questions. So that was really fun. And yes, thank you for Matt and thank you, KJ. And yeah, it's been so fun. I don't want this to end. So come join the 30 so we can keep hanging out. And you can still actually hang out with KJ and Matt. I don't know how you guys find time to make it every night, but they're like here. And Caitlin, thank you. I'm so excited. And Matt, yeah, Matt teaches too. Matt teaches in our launch pad. So it's not just me. We have a whole army of people that want to teach you, that love this type of style, and that we all like teach the same thing but just a little bit differently. So there's a lot of continuity. We've all been teaching together for years now. So yes, this was great. And Mary and Lynn, I'm so glad that you guys enjoyed it. This just makes my day. You don't even know. But hopefully we'll see you inside the 30. And if not, then still stay in touch. Okay, bye guys.